I welcome all the participants for the second technical session of day 5, which will be conducted by Dr. Sanjay Nikose. It is our immense pleasure, sir, to have you as our expert. Let me give a brief introduction about Dr. Sanjay Nikose. His qualification is MBBS. He is MD from MGI MS Sevagram Vardha. His experiences include he worked as a Chief Medical Officer IOFHS Government of India Ministry of Defence. He is a specialized medicine at RUSTAQ Regional Hospital Muhammad Oman. He works as a consultant medicine IBRI Regional Hospital Muhammad Oman Hospital, CEO Nahar Hospital Bhinmal Rajasthan. He is a director of Madhuban Hospital Trident Group. He is presently working as a director internal medicine Sagar Multi Speciality Hospital Bhopal. It is our immense pleasure, sir, that you accepted as a resource person in our Atal FDP. Now, I am going to hand over the session to Dr. Sanjay Nikose.
Thank you, ma'am, for welcoming me, as well as thank you for the brief introduction you had presented. And I would like to thank Tulsiramji Gaikwad-Patil College of Engineering and the AICTE Training and Learning Academy sponsored 1 week faculty development program, the organizers of these programs. I would like to thank both of you for inviting me over to give this talk on ML algorithms for disease diagnosis and prognosis. May I have this next slide, please? Yeah, this is the hospital presently where I am working at Bhopal. So this just gives a picture of that hospital. My main aim of the talk would be to give the participants a bird's eye view about the subject, something which is akin to viewing Himalayas from a vantage point. Then you decide which of these peaks needs to be explored and conquered. Can I have the next slide, please? Since you are all PhD students in artificial intelligence, I really do not need to present this slide. And you are already aware what is artificial intelligence, what is machine learning, what is deep learning, and natural language processing. So machine learning basically include learning from experience, understanding natural language, recognizing patterns, making decisions, and solving the problems. Next slide, please. This slide would just give a brief historical journey of the artificial intelligence, the main people who were involved in the development of the artificial intelligence. Down below is a diagram which will give the relationship between artificial intelligence, machine learning, natural language processing, and deep learning. So this artificial intelligence encompasses everything. Machine learning is a branch of it, and DL is a subset of that machine learning that uses models built on deep neural networks to detect patterns with minimal human involvement. Can I have the next slide, please? Since you're already aware of this, that this can be classified into two main categories: narrow, which is a weak AI, and general, strong AI. Strong AI as such doesn't exist. May I have the next slide, please? So, as far as artificial intelligence technologies encompasses several subfields, which includes, which as we have already mentioned in the previous slide. In addition to this, it also encloses robotics and computer vision. Can I have next slide, please? Coming to medical algorithms proper, they can be based on statistical methods, machine learning, or other AI techniques. Most practitioners use only a small segment of algorithms in medicine regularly. However, there is a growing need for the algorithms in healthcare as the volume of medical data increases. The concept of the algorithms in medicine transcends simple decision trees. It encompasses comprehensive guidelines that incorporate evidence based practices and clinical expertise to ensure patient care is both efficient and effective. The algorithm medical definition extends to wide range of applications from diagnostic processes to therapeutic management, prognostication, and patient monitoring. A medical diagnosis algorithm simplifies basically complex decision making by providing a structured pathway for evaluating symptoms, signs, test results, leading to a differential diagnosis or definitive diagnosis, but also improves patient outcomes by facilitating timely and appropriate interventions. So basically, what we want to do is utilize this machine learning methods to improve patient care. Can I have next slide, please? Examples of medical algorithms. I will come to the specific conditions subsequently, but before that, like examples of medical algorithms, there are protocols for management of chronic diseases like diabetes and hypertension, where specific steps guide and adjust the medication based on patient responses. Similarly, algorithms are used in emergency medical conditions like acute myocardial infarction, that is heart attack, and stroke, where rapid decision making is critical to achieve the best possible outcome. Development and implementation of an algorithm in medicine are grounded in clinical research and consensus among healthcare professionals. By following a medical algorithm, clinicians can navigate the complexities of patient care with greater confidence and precision. These healthcare algorithms are regularly updated to reflect the latest advancement in medical science and technology, ensuring that care is provided aligned with the current best medical practices. In summary, the application of clinical algorithms in healthcare represents a cornerstone of patient care, epitomizing a methodical and evidence based approach to medical decision making. The target of all this trouble is to improve the quality of patient care. Can I have the next slide, please? Types of medical algorithms. They could be diagnostic algorithms, treatment algorithms, clinical research algorithms, prognostic or predictive algorithms, prescriptive or predictive algorithms. By this, we mean that there would be certain algorithms, machine learning methods, which have been utilized to make a diagnostic analysis that they help in diagnosis. Some algorithms help in treatment. Some algorithms are there which are used in clinical research. Some algorithms are there, they will predict prognosis. We'll come to each of these conditions because I'll be concerned with diagnostic and prognostical algorithms. So in under this, we'll cover each of these conditions which are important. Okay. Next slide, please. Below are some of the main medical algorithms and their applications in medical diagnosis and prognosis. This is a list of medical algorithms which are used in medical diagnosis and logistic regression, support vector machines, decision trees, random forest, KNN, naive Bayes theorem, neural networks, also known as deep learning, Gradient booster machines. K means clustering, recurrent neural networks, and long short-term memory. XBoost, also known as extreme gradient boosting. Next slide, please. Then principal component analysis, Bayesian networks, reinforcement learning, and associated rule learning. So these are basically methodologies which have been enumerated. Out of these methodologies, can I have the next slide, please? The popular algorithms for prognosis are linear regression models, ridge and lasso regression, random forest, gradient boost machines, survival analysis model, what is also known as Cox proportional hazard model, deep learning. So these are the methodologies. Usually, as far as this is concerned, we utilize them for prognostication. Just a minute. Can I have the next slide, please? Just prognosis. Example application. Regression algorithms for prognosis basically predict outcomes. So prognosis as such implies what is going to happen to a particular patient when these things, the machine learning is utilized to or adopted to a particular clinical condition. So predict continuous outcomes like survival time, disease progression. For example, somebody is having pneumonia or somebody is having stroke. How is the disease going to progress? Secondly, survival time. Somebody is having cancer. How much time will he survive after a cancer is detected? Okay, so this by this we means that machine models, machine learning will be utilized for this process rather than discrete classes. Prognosis tasks often involve estimating how a disease will process on predicting the time to event, such as survival time after diagnosis. Examples will include cancer survival, Cox regression, or random forest can be used to estimate the survival rate of cancer patient based on variables like age, tumor size, what is the type of tumor, etc. Heart disease prognosis. Regression heart disease are of variety types, but this is just a general term to encompass heart disease. A regression models can predict the time to occurrence of a heart attack or stroke or the likelihood of recovery after surgery. Long short-term memory, LSTM, it is a type of recurrent neural network specialized for learning from sequential data, making it highly suitable for time series forecasting in healthcare. Prophet, a forecasting tool that was developed by Facebook and is useful for time series data with seasonal effect and missing data.
Sir, you are not audible, sir.
Okay, now am I audible?
Yes, sir. Actually, from the last 2 minutes, your voice is not
Okay,
audible.
I'll go back to this slide again. Okay,
Yes, sir. Okay,
okay,
sir.
okay, fine. Earlier, in the earlier slides, we have just generalized. Okay, generalized in the sense about the machine learning, about which all of you are well aware. Okay, various models that can be adopted. Now we will go into specific situations, specific clinical scenarios, how this has helped us. For example, pneumonia. As we all know, pneumonia is nothing but an infection of the lung. In the infection of the lung, whenever a patient happens, it has a wide spectrum of prognosis. This wide spectrum of prognosis would be from asymptomatic patient to symptomatic patient, very severe patient to death. The patient, when he comes to me, what happens is that the relative of the patient or the patient himself would first thing ask me, what is the severity of my disease? The second thing he is going to ask me is, am I going to survive or not survive? The relatives of the patient, suppose I tell him that your pneumonia is severe. The next question that comes is he going to survive or not going to survive? These are very common questions. Earlier, what used to happen is that we used to use certain things like what is the size of pneumonia, what is the age of the patient, and all these things. And by your own clinical experience or based on whatever is the clinical condition, we used to say, हाँ भाई तुम्हारा patient serious है, नहीं है, बचेगा नहीं होगा. That used to be a very subjective thing, and that could vary from observer to observer, clinician to clinician. Fortunately, what has happened with the adoption of this machine learning methods, we have been able to find out certain criterias which help us in assessing the severity as well as in assessing the prognosis. So when a patient first comes to me, I apply this and tells him, by this is the severity. Second, the likelihood that you will survive or not. So what are these? We will see in the next slide. Can I have next slide, please? So
So,
prognosis.
hello.
Hello.
Hello, sir. Actually, I have the question is,
Yeah.
what is the reason behind the pneumonia? Means like, I want to
It is
know the
infection
reason.
of the lung. This
Infection.
infection could be due to viruses,
Yeah,
could be
yeah,
due
yeah.
to could be due to bacteria, could be due to parasites, could be due to helminths, could be even a pneumonic patch. Would even a cancer can appear as a pneumonic patch. Even
Yeah.
tuberculosis can appear as a pneumonic patch. That's why in my last slide
Mm,
I had given that chest X-ray picture. That just shows that this is a consolidation. The etiology of which could vary. So that we have to find out based on investigations.
okay.
Okay. Huh. So shall
There
I?
may be chances of patient can't survive.
Yes.
Oh my God. Actually, my dad had this pneumonia, so that's
Huh.
why. In Corona period, yeah, my dad has expired, so there is shown in their death certificate. Pneumonia
Uh,
also mentioned there, so that's why I'm just asking about that.
yeah. I'm sorry to know that your dad couldn't come out of that COVID
Yeah.
epidemic. My full sympathies and empathies with you. But at the same time, these are certain models now which we use to predict. So now we have come to the curve 65 scoring system. Okay. In this, what
Mm,
the researchers had done is they have analyzed data of thousands and thousands and 10,000s of patients. After data,
mm,
what they did is went through machine learning and found out based on the variables that have been enumerated this that they put in the machine learning and found out which patient is like with what variables they are likely to survive, with what variables they are unlikely to survive. So the variables used here are confusion, urea, respiratory rate, systolic or diastolic blood pressure, age greater
okay.
than 65 years. For each of this they give 1 point. Okay. So if the score is 0 to 1, it is a low risk pneumonia. So the likelihood that the patient is going to die is only 1.5%. And such patients are most probably to be treated on OPD basis. They would not require even hospitalization. Those whose score is 2, the mortality in that case is 9.2%. Here, depending on a clinician's judgment, they might either want him to admit or treat an OPD patient. If the score is 3 or more, then the likelihood that the patient is not going to survive is 22%. Such patients are admitted, and those who have a score of 4 or 5 will require a admission in ICU. So this is one of the scoring systems that has been evaluated, found to be useful, especially at the time of admission itself. At time of admission itself, we can predict, or depending on the variables what are present, what is the scoring. This is the most likely prognosis. This is a patient who would most probably be possible to be treated on OPD basis. This is a patient whom we would like to hospitalize. This is a patient whom we would like to admit in ICU. Okay, am I clear about this? Can we go to the next slide, please? So now coming to the how these were right statistical analysis of the curve 65 in the derivative US cohort 30-day mortality for the curve 65 model versus a lasso penalized regression model. Non-linear effects were expected for the curve 65 element. So, natural cubic splines with 3 knots were applied to blood urea nitrogen, respiratory rate, blood pressure, and age elements. The Nassau penalty L1 to L5 was imposed on the logistic regression parameters to prevent overfitting, especially at the extreme values and after using spline transformation. As I have earlier mentioned, what we do in machine learning is take a data, allow this data to be passed through various machine learning models, and then come at a conclusion. However, again, we have to represent these guidance, these estimate. इसका मतलब ये नहीं है कि यही होने वाला है. This is likelihood. Most probably, this is what is going to happen. Similarly, what curve 65 we use at the time of admission. Then we have known what is known as pneumonia severity index or POTS curve, that is pneumonia outcome research trial. This pneumonia outcome research trial, again, it uses various variables, as you must be seeing in this slide, whether demographics, comorbids, what are the physical examination findings, what are the laboratory findings. So based on that, a scoring system is devised. With this scoring system, a total points are calculated and risk classes are there. So the risk classes based on the point total are 1, 2, 3, 4, 5. So here, patients in risk class 1 or 2 can be treated as outpatients. 3, again, plus minus, might be hospitalized, might be treated as OPD, depend on the clinician's judgment. But those with 4 and 5 patients need to be hospitalized. Yani कि they tell us that these patients with more scoring system of 4 or 5 risk class are more serious and they need to be admitted and treated intensively. Am I clear? Shall I go to the next slide? Okay, can we have the next slide, please? Again. Okay, so the descriptive statistics in PSI score or PORT score were used to define each variable. Categorical data were reported as proportions and counts, and continuous data were presented as medians and interquartile ranges, unless the data were normally distributed. Then the sensitivity, specificity, positive predictive value, and negative predictive value of PSI greater than 4 were calculated using the standard 2 by 2 tables. Univariate and multivariate logistic regression analysis were performed to identify independent predictors of the 30-day mortality. So this is how the machine learning is helping us for assessing the severity, and we can prognosticate if more severe, more likelihood of mortality, whether to treat him on OPD basis or whether to treat him on hospitalized basis. So taking one more example, let us have next slide, please. This is a condition called acute pancreatitis. Again, a severe condition, a condition where the pancreas in the body becomes inflamed, that is swollen over a shorter period of time. So this is basically what you see is the yellow region as a pancreas. Okay, it gets inflamed. In our country or internationally, we have this usually alcohol or gallstones, which are responsible for acute pancreatitis. 30%. 30% would be there which are idiopathic, for which we cannot know the cause. Okay, again a serious condition which can again have vast presentations, right from a typical abdominal pain to mild pain to very severe pain with shock ARDS can lead to mortality. So here again we have to really, whenever a patient is coming to us at the outside, we have to really prognosticate and estimate what is the severity, and secondly, what is the likelihood that he is going to survive. Next slide, please. So Here we have what is known as a BICEP score. So it is the bedside index of severity in acute pancreatitis. Five variables are measured within the first 24 hours and were found to be predictive of in hospital mortality. These five variables were blood urea nitrogen, impaired mental status, SIRS, that is systemic inflammatory response syndrome, age greater than 60, presence of a pleural effusion or not. Based on this, a scoring system was calculated. A 1 point system was given to each of these variables, and it was found that mortality was 0 when 2 points were there. It was less than 2, 3 to 5. Sorry, when 0 to 2 points were there, the mortality was less than 2%. When 3 to 5 points were there, the mortality was greater than 15%. So, this is how the BICEP score has helped us to prognosticate on these five variables. If a patient is coming, I'm just seeing these five variables because the relatives of the patient have to be told by your patient has so much of severity, likelihood of survival or likelihood of mortality is less than 2% or greater than 15%. So that is how the machine learning models are helping us. May I have the next slide, please? Similarly, we have for the same condition acute pancreatitis, what is known as the Ramson's criteria for pancreatitis associated mortality. So, based on variables at admission and within 48 hours of the admission, these are the variables at admission: age, WBC count, what is this glucose level, what are the LDH levels, what are the AST levels. Within 48 hours, whether the hematocrit has fallen by greater than 10%, whether there is a rise in blood urea nitrogen by greater than 5 milligram, is his calcium less than 8, what is the SpO2, PaO2 basically, it is what is the base deficit fluid sequestration. Then, if gallstones is there, what is the these are the criteria, and within 48 hours, this. So, based on this scoring system, we calculate the number of points. If it is 0 to 3 points, the associated mortality rate is low. It means the severity is less. So, the mortality is 1%. 3 to 4, it increases exponentially from 1% to 15%. So this is like intermediate severity. This is 0 to 3 mild severity. If the point system is 5 to 6, again it doubles, almost doubles to triples to 40%. If greater than 7 points, the patient is unlikely to survive. So this is how again all this data which is collected is put through machine learning models, and after the machine learning models they predict this severity and associated mortality. Let's go to the next slide, please. Another clinical condition ischemic heart disease, जो कि आप लोग जनरल लैंग्वेजेस में हार्ट अटैक कहते हैं. So again the heart ischemic heart disease could vary in the spectrum from angina pectoris, unstable angina, acute coronary syndromes, which could be ST elevation myocardial infarction, to non-ST elevation myocardial infarction. In asymptomatic patients, for symptomatic patients, we have different models, but in asymptomatic patients, in patients whom we suspect they could be having ischemic heart disease, what we do is they undergo what is known as treadmill test. In this side picture, you can see what is the treadmill test. Here, a patient walks on a treadmill machine and his ECG is continuously recorded. The interpretation of the ECG is done, of course, manually. It cannot be done by the machines. And after this is done, can I have the next slide, please? We calculate what is known as Duke treadmill score. Okay. Now, this Duke treadmill score is nothing but a point-based system to predict 5-year mortality based on treadmill ECG stress testing in patients who are not known to have coronary artery disease, but who have risk factors for coronary artery disease. This risk factors could be smoking, hypertension, diabetes, hyperlipidemia. Age is the biggest risk factor for coronary artery disease. So, those with risk factors but no known coronary artery disease, they undergo this treadmill test. After undergoing treadmill test, this Duke treadmill scoring system is calculated. The variable here are the exercise time in minutes. This is how it is calculated. Duke's treadmill scoring minus 5 into ST deviation, whether elevation or depression, minus 4 into angina index. The excess time is based on using the standard Bruce protocol. ST deviation refers to maximum ST change, that is elevation on depression in any leads except the AVR. The angina index gives 0 points if no angina occurs, 1 point if there is non-limiting angina, and 2 points if angina occurs. Based on this, a score is calculated, which is known as Duke's treadmill score, and patients are categorized as low, intermediate, and high risk. So, low score are those whose score is greater than 5. Okay. Here, the 5-year survival, that is the 5-year likelihood, is 97%. They are not going to get coronary artery disease. That is the 5-year survival. 4 to minus 11 is the intermediate score, which indicates a 5-year survival of 90%. Means 90% of these patients are unlikely to get coronary artery disease or heart attacks in the next 5 years. High score is less than minus 11. It indicates a 5-year survival of 65%. In high-risk patients, 74% of the patient had 3 vessel or left main coronary artery disease on angiography. All these patients, after they had performed in the study, this was a study done initially, this was a research-based study. So validate this score of Duke treadmill. In this study, what they did is all the patients underwent Duke treadmill score. After undergoing and calculating, what they did is all of them underwent angiography, and they found whether they have coronary artery disease or not. So they validated that those who have this score will have this much likelihood of survival or unlikelihood of getting the coronary artery disease. Okay. Next example we take is the cardiac arrest. Cardiac arrest is a condition where the heart suddenly stops. You must have seen very many cases, or at least heard of them, where what happens is a person is walking and he suddenly falls down. He doesn't have a pulse, he doesn't have a respiration, and he falls unconscious. This is what basically is cardiac arrest. So, this cardiac arrest, then the question comes, when a person undergoes cardiac arrest, is he likely to survive? Okay, this is the most important question whenever a person is going under cardiac arrest. So, for this cardiac arrest patients, we have what is known as prognosis after resuscitation score, which will predict neurological outcome and survival after cardiac arrest. What happens in cardiac arrest is immediately heart stops pumping the blood. When the heart stops pumping the blood supply to the brain, to the heart, all the organs of the body is interrupted. When this blood supply is interrupted, brain, which is critically dependent on oxygen for its metabolism, is the first organ to undergo injury. Certain other organs have some reserve, so they can utilize that as a metabolic fuel. So the brain in these conditions, when the interruption of oxygen to the brain is there, within 3 minutes, the brain cells will undergo death. Once the brain cells undergo death, the chances that patient will recover, unless and until the blood flow is restored to the brain, are very minimal. We don't know whenever a patient undergoes or a person undergoes cardiopulmonary resuscitation outside the hospital or inside the hospital, how effectively that CPR is being performed. Okay, so we really don't know what is the quality of that CPR and whether the blood flow to the brain or vital organs like heart has been restored or not. So it is very difficult to say that after a cardiac arrest, what will be the prognosis. So this prognosis scale or a prognosis after resuscitation score was developed. How it was developed? A lot of variables were taken into account. They underwent statistical analysis, machine learning, and after that, they predicted this. So, what were the variables used? Whether the person who had cardiac arrest was having a non-metastatic malignancy, was in sepsis, was having a dependent functional status, was having a pneumonia, what was his creatinine level, what was his age, did this cardiac arrest occur because of myocardial infarction? After this, a calculation is done. A score greater than indicates that a person undergoing cardiac arrest is unlikely to survive. So, this is again one more predicting outcome. Next, we will take the example of what is known as a transient ischemic attack. Transient ischemic attack is a temporary blockage of blood flow to the brain. So, whenever, as we have discussed earlier, what happens is that whenever there is a blockage of blood flow to the brain, in cardiac arrest, there is a global interruption of blood flow to the brain. In stroke, what happens is there is a focal interruption of the blood flow to the brain. Within that stroke, there is a permanent interruption. In transient, it is a temporary blockage of blood flow to the brain, which is also known as a mini stroke. So, mini strokes are usually harbingers of large strokes. Means it is something like a warning sign. Warning that yes, now chances are that this patient might have bigger stroke. Okay. So now we need to estimate what are the factors which predict that this particular individual will end up with stroke. What are the factors which individual will not land up with stroke? For this, can I have the next slide, please? A scoring system has been devised which is known as ABCD or ABCD2 stroke score for transient ischemic attack. It uses variables like age, blood pressure, clinical symptoms, duration of symptoms, and additional factor that is the diabetes. A scoring system is devised where one score is given to age and systolic blood pressure greater than 40 and diastolic blood pressure greater than 90. Clinical symptoms, if there is unilateral weakness, the score is given 2. Speech disturbance without weakness, okay, then here I think I have missed this speech disturbance without weakness. If the duration is greater than 60 minutes, the scoring is 2. If it is 10 to 59 minutes, it is 1. If less than 10 minutes, then it is 0. Additional factor is diabetes. This score is calculated. Can I have the next slide, please? Yeah. After calculating this score, if the score is 0 to 3%, it is known as low risk. Why low risk? Because the 2-day stroke of risk is 1%, the 7-day stroke risk is 1.2%, and the 90-day stroke risk is 3.1%. Yani ki those people who have this are unlikely to have a major stroke, very less chances. Moderate risk is 4 to 5%. So 2-day stroke risk in moderate risk is 4.1%, 7-day stroke risk is 5.9%, and 90-day stroke risk is 9.8%. Similarly, 6 to 7 points is high risk. 2-day stroke risk is as high as 8%, 7-day stroke risk is as high as 11%, and 90-day stroke risk is 17.8%. So these are the moderate risk and high risk patients whom we are going to aggressively intervene. Okay. For this, what has been done? For calculating this risk from the variables that we had seen in the ABCD or APCD2 score, univariate Cox proportional hazard modeling was performed separately for each of the risk score to estimate the hazard ratios relative to the low risk category during 7 days, 30 days, and 365 days after the transient ischemic attack. The concordance index statistics was calculated to allow comparisons between the models. The interpretation of C index is similar to the area under the curve in the receiver operating curve analysis. So this is how, again, one more example of prognostication after DIA. Again, using the machine learning models, this is how we can help. Because naturally, a person with stroke, if a person is coming with TIA, the next question, how likelihood that he will end up in stroke? So this calculation of ABCD2 score is helping us to give us a figure that the chances are so percent. Now, I don't know whether he is in 3% category or 97% category, but the chances are 3%, like that. Okay. Next slide, please. Another serious condition known as sepsis. What is sepsis? In which the body responds improperly to an infection. The infection fighting processes turn on the body, that is the inflammatory system. What does the infection do? The infection induces inflammation in the body, and instead of killing the infective agent, it kills the infective agent, and at the same time, because of the hyper responsiveness of the inflammatory system, it also attacks the organs of the body, okay, causing the organs to work poorly. So if the sepsis is severe, it can lead to septic shock, which causes a high mortality. Sepsis nowadays is one of the most leading cause of death in India and in the world. And hence, there was a need for prediction models to estimate what is the severity of the sepsis. Secondly, how the sepsis is progressing, whether it is improving or regressing. And third, what is the likelihood that a person who is getting sepsis is going to survive or is not going to survive? Okay, can I have next slide, please? So I have taken this article from Journal of Critical Care. Okay, and the research workers were Inger Presson, Andreas Makura, and David Besidas. They did a study. Okay, and they did a study and developed an algorithm which is known as Nevo algorithm Nevo sepsis. What does it do? Prediction of sepsis in intensive care patient using machine learning methods. It was nothing but a prospective randomized clinical validation study. So the sepsis risk prediction were calculated, okay, by Novi sepsis algorithm based on the following 20 variables. Like we see, whenever we are calculating something, we need variables. Here, these 20 variables used for calculation, that is age, sex, heart rate, respiratory rate, temperature, what is the systolic blood pressure, what is the diastolic blood pressure, whether the patient is on vasopressor use or not, what is the serum creatinine level, what is his glucose, lactate levels, platelet levels, WBC count, blood urea, nitrogen, bilirubin, pH, oxygen saturation, pulse oximetry, fraction of inspired air, FiO2, if he is on any respiratory support mechanism, either through non-invasive ventilation or invasive ventilation, internationalized ratio, and Glasgow Coma scale. So these are the 20 variables which were used by this research worker. Although there are variable models, this is one of a very good model which has been validated. So Nevoy sepsis could predict the development of sepsis according to the sepsis 3 criteria 3 hours before the onset of sepsis with high performance accuracy. The accuracy was 79%, 0.79, sensitivity was 0.80, and specificity was 0.78. That is, sensitivity was 80% and specificity 78%. So, Nevoy sepsis is a prediction algorithm developed by use of machine learning methods. So, this is one more utility or one more area where the machine learning has been utilized for prediction of sepsis. Why? Because it is a severe condition. That's why we need a prediction model. Okay. Can I have next slide, please? So the performance metrics for algorithm predicted sepsis 3 hours in advance. This is the number of patients. This is the sensitivity, specificity, positive predictive value, and negative predictive value. This is the with the calculation using 95% confidence interval. Okay, so it is not a very good because the sensitivity and specificity are not really very high. When we see, say, sensitivity of 80% and a specificity of 78%, but at least it helps us. You know, for a test to be good, we should have a sensitivity of very large. Specificity should also be high. Sensitivity will pick up true patients. Specificity will leave true negatives, like that. This is a test of true positive sensitivity, and specificity is a test of true negatives. So a test which has a very high specificity and sensitivity is a very good test. This Novoy algorithm, though not reaching that point where it should be or it can be recommended by medical authorities to be used, because we don't have any model. So this at least helps us in estimating some prediction regarding the severity of the sepsis. Can I have the next slide, please? For sepsis, we have what is known as the sequential organ failure assessment score, what is also known as SOFA score. This SOFA score is a sequential. Okay, what it helps? It helps us to estimate the severity of the sepsis. Again, these are the variables like respiratory rate, okay, then coagulation, liver, cardiovascular system, like what is the blood pressure, whether he's on inotropes, is not on inotropes, what is the Glasgow coma scale, what is his kidney function level. Based on this variable, it is a continuous system. Means this SOFA scoring system has to be done daily. Based on the SOFA total score, we know whether a patient is improving or deteriorating. So with this score, we can tell the patient's relative, देखो भाई, कल तुम्हारा सोफा स्कोर पेशेंट का इतना था, आज इतना है, अच्छा हो रहा है या बुरा हो रहा है, like that. So it helps us give numbers. Okay, otherwise it becomes very subjective to explain to the patient related, भाई तुम्हारा पेशेंट ऐसा है, उसको होश नहीं आ रहा है, वो आइनोट्रॉस पे चल रहा है, उसको वेंटिलेटर पे चल रहा है. Then what this helps us in giving a scoring system to objectively tell them, see, this was the scoring system today, this is the scoring system 2 days back, this is the scoring system 1 day back, and this is how your patient is progressing or deteriorating. So this is how it is going to help us. This is again a statistically validated model and is used all over the world in critical care medicine. Can I have the next slide, please? Another condition, a very common clinical condition, which a very adverse prognosis in terms of quality of life as well as terms of survival, that is stroke. Okay, stroke could be a hemorrhagic stroke or a ischemic stroke. Ischemic stroke, as we had seen in the TIA, a clot blocks the blood vessel area of brain which gets blood supply by that vessel becomes dead. Or it can be hemorrhagic stroke where what happens, the blood supply is interrupted because the blood vessel is weakened and it ruptures. Blood clot is formed. So what happens is that the areas of body which are supplied by that particular area of the brain undergo atrophy. Okay, so this is basically the stroke. Now, when this happens, this is a potentially mortal condition where the patient will have a poor prognosis of life he survives or a very high incidence of mortality also. So we have to tell them कि भाई अभी आपको स्ट्रोक हुआ तो क्या होने वाला है, ठीक है ना, बचोगे नहीं बचोगे, बचोगे तो वेजिटेटिव स्टेट में जाओगे या बचोगे तो विल you have a good quality of life or a very poor quality of life, like that we have to prognosticate. Can I have the next slide, please? Okay. So for this, we have what is known as the NIHSS score for stroke, that is National Institute of Health Stroke Scale. Okay. And here it is a 15-item neurological examination stroke scale, which is used to evaluate acute cerebral infarction. So the stroke severity based on this is calculated as either very severe when the NIHS score is greater than 20, score greater than 15 to 25, 24 qualifies as a severe stroke, 5 to 14 is mild to moderate stroke, and mild stroke is 1 to 5. So how are the outcomes related to NIHS score at admission? If the score is less than 5, 80% of the stroke survivors will be discharged to home. If the score is between 6 and 13, typically they will require acute inpatient rehabilitation. Scores of greater than 14 frequently require long-term skilled care, and a score of greater than 16 forecasts a high probability of death or severe disability. So, this is how the NIHSS scoring system helps us to prognosticate. So, as we have already told, that there are various variables. What variables? We will come to the next slide. Next slide, please. So, these are the variables that are used. Okay, and using these variables, the calculation is done, and which we have seen in the previous slide, scoring system is done, and based on the scoring system, we are able to prognosticate, give a figure that the chances of survival are this much, chances of good recovery are this much. So this is again one of the methods that helps us in prognostication. Can I have the next slide, please? Now, coming to machine learning in diagnosis, what we were till now doing is machine learning in prognosis, and what are the available things to us, or what has been done till now in prognostication of a disease. Now, we will go to the diagnosis, machine learning, how it helps us. Traditionally, diagnosing a disease involves taking a detailed history, making a differential diagnosis, ordering tests to confirm or rule out possible diagnosis, and finally arrive at a diagnosis. It relies heavily on doctor's experience and his knowledge. While his expertise is invaluable, it is not without limitations, especially with rare diseases or unusual presentations. A disease can have variable presentations. So, unless and until a person is aware of all the presentations, it becomes very difficult. Sometimes a diagnosis may be missed. This is where machine learning helps us. What it will do, we might have a machine learning model which will incorporate data from everywhere. Okay, so in rare cases, rare presentations, this will pick up and this will guide a clinician. Yes, this could be a possible differential diagnosis. Okay, human error can occur while interpreting complex and voluminous medical data. This is where the AI steps in, offering a powerful tool to assist the doctors in diagnosis. The machine learning, a subfield of AI, utilizes vast amount of medical data to learn and improve diagnostic abilities. AI can identify patterns and relationship in data without explicit instructions. With more data, AI systems become better at recognizing patterns, identifying potential diseases, and even predicting the likelihood of certain diseases. AI algorithms can analyze medical images like X rays, CT scans, MRI scans with incredible accuracy, can detect lung cancer nodules on X rays, abnormalities in mammograms at a very early stages, and can potentially lead to early diagnosis and better treatment outcomes. This is how the AI will assist a doctor in his diagnosis. Can I have the next slide, please? So, popular algorithms for diagnosis. These algorithms are used to classify whether a patient has a particular disease or not based on input features, and those input features would be symptoms, signs, lab results, imaging, etc. The goal is to predict a class label, that is disease versus no disease, or the type of the disease. Popular which I used are logistic regression, decision trees, random forest vector machines, K nearest neighbor, that is the KNN, support vector machines, naive based deep learning neural networks. Can I have the next slide, please? Clinical examples. So, machine learning is increasingly being employed in cancer detection. As we know, certain serious conditions or conditions which have a possibility of having a various adverse outcome, and the importance that when these conditions are detected early, they can be treated in such a way that we get cure. Suppose a cancer which is detected in very late stages, it will be very difficult to cure. Whatever steps are taken, mostly in advanced stages, are palliative treatment. If suppose the same cancer would have been detected in an early stage, possibly a curative method of therapy would have been adopted so that a patient is free of cancer or some other diseases similarly. Okay, so machine learning is increasingly being employed in cancer detection and diagnosis. Cancer prediction will become quite easy in future, and we can predict it without the need for going to hospitals. As we can see, many technologies are being used and tested in the medical field. So by this we can say that this will make it easier in future to detect cancer. We are testing which algorithm will give us good results among CART, SVM, and KNN. We are making a cancer prediction using machine learning in three types of cancer quite frequently. That is the breast cancer, lung cancer, and prostate cancer. In breast cancer, we are using SVM algorithm, and for lung and prostate cancer, we are using random forest algorithm. We are going to give different attributes for this three cancer system where the user has to enter the data to get the result. Okay, maybe possibly may not, at least at the stage of screening, what will happen is these screening methods are available online. A patient or a person can himself enter those data, and in those calculators he can see whether he is having that cancer, not having that cancer, what is the likelihood that he is going to get that sort of cancer. We'll go now to clinical examples. Okay, clinical example is breast cancer, another very common cancer which kills lots of patients and is potentially very curable if detected in early stages, and a very good life expectancy can be used. So, what we have is a breast cancer risk assessment tool, BC RAT. It is also known as the Gale model. The health professionals are able to estimate a woman's risk of developing invasive breast cancer over the next 5 years and up to the age of 90, which is supposed to be a lifetime risk. So, what are the tools or what are the attributes that are used? Age at first menstrual period, age at the time of the birth of a child, family history of breast cancer, number of past breast biopsies, number of breast biopsies showing atypical hyperplasia, race, and ethnicity. Based on this, we are calculating, and that calculation is that a women with a 5-year risk of 1.67% or higher are classified as high risk. A 5-year risk of 1.67% is a FDA guideline for taking risk reducing drug to lower the breast cancer. So this is how the BCAT BC-RAT tool helps us in estimating what is the risk of breast cancer. What we have to know that this might not. Can I have the next slide, please? I'll give you example like this for this breast cancer. We don't have only the Gale model or the BC-RAT model. We have other models also which have been developed by other research workers like the Klaus model, the BR Capro model, the Tyrer-Cuzick model, and BOA-DCA model. So these models are used by various research institutions, various research workers. They try to develop, yeah, they are developing this model or they have developed this model using various criteria as has been enumerated in this chart, and they allow the statistics or this data which is collected to undergo machine learning models as enumerated earlier, and then they calculate what is the risk. High risk, they are able to predict. Low risk, again, they are able to predict. This is how they are able to calculate or diagnose models. Okay. The next example I will take is that of lung cancer. As I have earlier said, cancers are a very bad thing. Bad thing in the sense that they are diseases which have the potential to be diagnosed early, treated fully, and possibly the patient can have a very good quality of life if he undergoes curative therapy. Once it is advanced, the only option available is that the patient remains suffering, and to mitigate this sufferings, what will happen is that he has only palliative treatment or palliative therapy is available. The life of the patient becomes shorter. When we talk of lung cancer, various models. So lung cancer is the primary cause of death from malignancies in both the genders. It is worth noting that the death from the lung cancer exceeds death from cancer of colon, cervix, and breast combined. So, various models for assessment of lung cancer are LC-RAT, that is the lung cancer risk assessment tool, LC-DRAT, that is the lung cancer death risk assessment tool, NOD Trondelag health study, that is the what is also known as Hunt model, optimized early warning model for lung cancer risk, also known as OWL model. So these are the various models which are available as of date. They use various attributes which puts a patient at high risk of developing lung cancer, and then once these attributes are going through a machine learning model, these models have been developed. Okay. Can I have the next slide, please? So several researchers implied neural network, support vector machines, and decision tree, convolutional neural network based on non-linear cellular automata, random forest, XGBoost, and logistic regression. So these are basically machine learning models. Okay. And based when this data, what is the clinical data used? It has been enumerated down below. So this data is applied via this machine learning models, and what you get is a clinical data set to predict the recurrence of lung cancer and its survivability. So what is the clinical data used? One is the gender, one is the age, smoking, yellow fingers. This refers to whether participant has yellow fingers or not, anxiety, okay, peer pressure, chronic disease, fatigue, allergy, wheezing, alcohol use, coughing, shortness of breath, swallowing difficulty, chest pain, okay, whether he has been diagnosed earlier with lung cancer or not. So all these attributes are put as enumerated in the earlier slide, through those various machine learning tools, and the risk prediction is done by the models which I had enumerated in the slide before earlier. Okay. Next example we will take that another a very common cancer is that of a prostate cancer. Okay. Can I have the next slide, please? Yeah. So prostate cancer is the second most common cancer and the fifth leading cause of cancer attributed death in the men worldwide. Currently, there is no population based screening program for cancer prostate. There is a strong association of PSA, which is known as prostatic specific antigen, with cancer prostate. It is an antigen or it is a secretion of prostate organ. However, though it is relatively inexpensive, measuring PSA levels is relatively inexpensive, which has made PSA a key biomarker in the diagnostic tool of cancer prostate. However, it is not a cancer specific marker because this PSA can also be secreted in conditions like benign prostatic hypertrophy, prostatitis, and other non malignant prostatic condition also. So, this leads to confusion regarding the application of PSA levels at a test for screening of prostate cancer. Okay. Again, because of this, there is a limitation on its specificity and sensitivity and is largely dependent on setting a cut-off point, which often leads to an acceptable number of false positives and false negative results. Can I have next slide, please? To address such PSA limitations, researchers have incorporated other measurable factors into approaches for early detection of cancer prostate. These risk assessment tools are based on statistical models which are designed to improve the accuracy and performance of PSA tests. So, logistic regression and artificial neural networks models are now considered to be the most common and effective statistical techniques in aiding the development of new models to enhance early prostate cancer diagnosis. This cancer prostate risk prediction models can be used to aid the testing of men for further investigations. Can I have next slide, please? We are taking another example, what is known as the 10-year risk for atherosclerotic cardiovascular disease. So, atherosclerotic cardiovascular disease are a leading cause of cerebrovascular disease, coronary artery disease, peripheral vascular disease. Okay. So what does this calculator do? This AS 10 years, what is known as 10 years ASCVD calculator, fortunately is available online. This helps us as a clinician to identify patients for whom I have to start statins or not to start statins, depending on their risk. In addition to this 10 years ASCVD calculator, we have other variables too, which will tell me, suppose a person is having established coronary artery disease or coronary cerebrovascular disease, he is a candidate for statin therapy. Okay, irrespective of his cholesterol levels. Okay. Then another condition would be somebody who is having a LDL levels of greater than 190. Again, he is a candidate for statin therapy. Here the question comes, there might be a person who doesn't have coronary artery disease, who doesn't have cerebrovascular accident, cerebrovascular disease. He got his cholesterol lipid profile done based on his presence of other disease or absence of other diseases. We have to calculate a risk profile to see whether statin therapy needs to be initiated or does not needs to be initiated. So the atherosclerotic ASCVD risk estimator categorizes the predicted 10-year ASCVD risk into low risk, that is less than 5%, borderline risk 5 to 7.4%, intermediate risk 7.5 to 19.9%, and high risk greater than 20%. How does it do? The risk calculator uses variables. Okay, these variables are gender, age, race, systolic blood pressure, diastolic blood pressure, whether the individual or the patient is on antihypertensive treatment or not, whether he's smoking, what is his cholesterol total, high density cholesterol, low density cholesterol, and a history of diabetes. So, logistic regression models were used to assess the relationship between the ethnicity and atherosclerotic cardiovascular scores. Four different types of statistical tests were applied: linear regression analysis, chi-square analysis test, Mann-Whitney U test, and Kruskal-Wallis analysis. So, based on this, what we do is we calculate the atherosclerotic risk, and it helps us to tell whether a person or a patient will require statin therapy, and at the same time how intensive that statin therapy should be. Can I have next slide, please? Another example is stroke prediction. Okay, what we had earlier seen was a severity of the stroke. Now, are we in a position to predict whether a person is going to have a stroke or not? Okay, can I have next slide, please? Yeah. So, stroke is a devastating cerebrovascular event that results in significant mortality and morbidity and is a leading cause of death and disability. So, timely identification of individuals at risk of stroke plays a crucial role in implementing preventive measures and improving patient outcomes. With advances in machine learning and predictive analysis, there has been a growing interest in using this technique to develop accurate stroke prediction models. Moreover, machine learning models can integrate multiple clinical parameters and risk factors to to personalized risk score, aiding in individualized patient management. So the stroke prediction task was performed using NB, LR, SM1, KNN, DT, RF, XBoost, and NN models. The accuracies obtained for each of these techniques were as follows: NB was 89%, LR 95, SPM 95, KNN 95, DT 92, RF 95, XBoost 94, and NN 95. Again, a very high degree of accuracy. Can I have next slide, please? So, what are the attributes which undergo those statistical analysis? So, these are the attributes: gender, age, hypertension, heart disease, ever married or not, what is the work type, what is the residence type, what is the average glucose level, what is the BMI, what is the smoking status, whether earlier he had stroke or not. Okay, can I next slide, please? So, potential benefits of machine learning in medical diagnosis. So earlier we had seen with examples. I'm sure all of you are available of all the machine learning tools and all these things, how to calculate this, what are the tools available, etc. So it was not the task of this talk to go into details of all these things, but those have been enumerated just to show that what are the machine learning tools that have been used in individual examples. So, what are the potential benefits of machine learning in medical diagnostics? One is early detection, higher sensitivity and specificity enables some machine learning technologies to detect certain diseases earlier in their progression than conventional methods. Also, may allow non specialists to quickly screen patients and see the likelihood or high risk patients. Then, consistency. The analysis of patient data will be more consistent. They reduce variations in diagnosis of a disease. They track the disease progression consistently. Assess. Because of the availability of the machine learning in medical diagnosis, the access can be increased in undeserved areas, reach more in home and smaller clinical setting, automate certain tasks to reduce provider workload. So these are the potential benefits of machine learning in medical diagnostics. Okay. Next slide, please. However, any new thing or anything which is in development can never be without challenges. So, what are the challenges? The challenges are, one is there is a limited data on real world performance. Providers may be hesitant to adopt technologies without evidence of effectiveness in a real world setting. Developers may be hesitant to spend significant time and money without assurances that it would improve technology adoption. Challenges, again, another challenge is medical meeting the medical needs. Technologies that are developed may not address a clear clinical needs. Means somebody has made a model. Now, unless and until that model has a clinical utility, you don't expect any medical professional to use such models. For example, whatever we had earlier seen, those models, we are using it in a routine clinical care because with the help of those models, we are able to diagnose, we are able to prognosticate, we are able to predict, and we are able to tell patients. Sometimes we are able to give the numbers. This is the likelihood that the patient is not going to survive. This is the likelihood that the patient may survive, like that. Then the technologies may not integrate with the existing healthcare system and the clinical workflows. Provider want to understand the clinical evidence for recommendations. Naturally, as a doctor, I would like to want whether there is any evidence, whatever recommendations come out of it after the machine learning method, whether there is any evidence that is have any benefit or not. A lot of times, what happens, we have very fantastic pharmacology models, drugs being developed, but when they are tested, they have no utility. Theoretically, they say, oh, such and such drug belonging to such and such class of drug, very effective. Go in that. They test it in lab, they test it in mice, very effective. But when you test it on a person, it is highly ineffective. So, whether this has any evidence that it is helpful in a clinical scene. So, these are the challenges. Can I have next slide, please? So, what are the potential policy options to address these challenges? The policy options are, when the policymakers could create incentives, guidance, or policies to encourage or require the evaluation of machine learning diagnostic technologies across a range of deployment conditions and demographics representatives for intended use. This would help identify biases, limitations, and opportunities for the improvement. Could lead to increased adoption by enhancing trust, may be costly and time intensive, which could delay the movement of these technologies into marketplace. So policymakers could promote collaboration among developers, providers, and regulators in the development and adoption of machine learning diagnostic technologies. Could help ensure that technologies address clinical needs and integrate into medical workflow. Could help with creation of an access to ML ready data. Can I have next slide, please? In conclusion, AI can be used to diagnose diseases, develop personalized treatment plans, assist clinicians with decision making rather than simply automating tasks. AI is about developing technologies that can enhance patient care across healthcare settings. However, anything that comes new is not without challenges. Challenges related to data privacy, bias, and need for human expertise must be addressed for the responsible and effective implementation of AI in healthcare. Next slide, please. And thank you all for the patient hearing.
Yes, dear participant, is there any query or any questions you can ask to sir? Sir is available for the question answer session. So anyone have any doubts or any query, you can ask to sir. Sir is ready to answer.
Look like there are no questions. No problem. I think we can end the session.
Yes. Uh,
Okay.
on behalf of the institute, I thanks Dr. Sanjay Nikose sir who has spared their time from his busy schedule and give a very informative sessions to this AICT Atal online FDP on leveraging machine learning and data science on healthcare and medtech. So thank you, sir, once again. On behalf of the institute, I thanks all the participants, those who are patiently listening the all the sessions and present in all the sessions. So thank you so much, everyone.
Thank you. Thank you
Uh,
all.
yeah, dear
Thank
participant, tomorrow we have session from 2:30. So all must be joined on time. So thank you so much, everyone. Thank you, sir. Sanjay. I request Sudha madam, please stop the recording.